عليكم أعزائي الطلاب. محاضرتنا لهذا اليوم راح تكون عن موضوع Burns are one of the most severe traumas that a human being can be exposed to. First, I want to remind you about the anatomy of the skin. It is composed of two main layers, the superficial epidermis and the deeper dermis layer, which is thicker than the epidermis. The dermis contains the skin appendages that are required in healing of superficial burns. What is burn? Burn simply is injury of the skin and underlying tissues due to exposure to either a physical energy or a chemical agent. The physical energy may be heat, electricity, ionizing radiation, UV light, etc., while the chemical agents may be alkalis, acids, phenols, and organic solvents, phosphorus, etc. So the etiology of burns are first physical factors, second chemical factors. The physical factors include heat, and heat may be dry as in flames or may be wet as in hot boiling water, and in this case the burn is called scald. The other kind of burn by heat is by fat, such as during frying, and in this case the burn is more severe because the fat heat is more than, or the fat temperature is more than 180 degrees, while the boiling water temperature is only 100 degrees Celsius. The other causative factor of burn is extreme cold. It is the reverse of heat, and in this case the burn is called frostbite. Burns may be also be caused by electricity, and electricity may be either AC or DC or thunder and lightning, and in this case the burn may be either due to direct electricity passing through the body, or due to the heat of the electricity, and in this case is called the flash burn. Mechanical friction is another causative physical agent for burns. You all have tried a new shoe, and you see that when you wear a new shoe, blister is formed in the back of the foot, and this is due to the friction or mechanical friction inducing a second-degree burn. Ionizing radiation is another cause for burn, and these include X-rays, gamma rays, and this is usually seen in medical field tumor management. Ultraviolet light, such as the shortwave ultraviolet, are also a physical factor that causes burn, and is usually seen in a burn due to sun exposure. Chemical factors that causes burn are classified into strong acids and alkalis. يعني مثل عليه التيزاب أو الفلاش مال تنظيف التواليتات بالبيت. الالكاليز include القاصر، الجيف اللي ينظفون به الطباخات. The other chemical factor that causes burn are petroleum distillates, مشتقات البترول. In this case, if the petroleum distillates مثل البنزين أو النفط get in contact with the skin, with time it will induces injury to the skin and causes burn, even if these distillates were not burned by heat. Chemicals that solvents that used in industry and domestics, such as phenols، مثال عليها الديتول والمعقمات، كل هذا يسبب burns. Also it's due to chemical factors. In wars, phosphorus and phosphorus weapons also may causes burns, and there are other chemical factors that causes burn other than these. Burn severity is determined mainly by the depth, that's to say the level of injury in the skin, how deep it gets down, and the extension of this injury, that's to say how much the area in the body that's involved by the burn. And this severity of the burn or the depth of the burn depends on the temperature of the agent or the concentration in case of chemicals. The more the temperature or the more the concentration, the deeper the burn will be. The mode of heat transmission, whether it is by contact, radiation, or phlegm. The duration of the contact. The longer the duration of the contact of the injuring agent, the deeper will be the burn. Skin thickness. There is the skin thickness in the body differs from one side to another. For example, the skin is very thin on the eyelid, while it is very thick in the back of the body. Therefore, burns of the eyelid tends to be more severe than those in the back of the body, where they are both exposed to the same injuring agent regarding its temperature or concentration. Iatrogenic factors that during the burn treatment, iatrogenic, that's to say induced by the doctors. For example, when you forget to cover or dress the burn, it will develop dryness, and in this case it will develop more injury and get deeper. Contamination during change of dressing will also cause infection, and infection causes the burn to get more severe. Inadequate fluid resuscitation, such as giving not enough IV fluid to the patient, will cause shock, and this will cause peripheral vasoconstriction and will cause more damage to the burn. In this figure you can see that there are three zones in any burn area. The zone that's exposed to the most severe traumatic or injury of the traumatic agent is called the zone of coagulation. In this case, there is necrosis, the coagulative necrosis of the cells in this zone, which is exposed usually to the highest concentration or the highest temperature of the injuring agent. This zone is usually surrounded by a zone of stasis. In the zone of stasis, the cells here are in shock state by the injury. They are neither fully viable nor they are dead. However, within the next 24 to 48 hours, they may either transform to necrosis or they get recovery, and therefore the burn resuscitation aims to make this zone of stasis get the maximum recovery as possible. These two zones are usually surrounded by the third zone, or zone of hyperemia or inflammation, and in this case zone is characterized by vasodilatation due to inflammatory mediator release. These next two figures shows you the most common home accidents that causes burn. For example, when you open hot water, boiling water, or when a child comes to the cooker and spoils boiling water on herself. In this case, the first step in the management of those cases is to cool the area by cold water as soon as possible. You can see that the burn gets more severe the deeper it gets in the body. So the most superficial burn is called the first degree burn, in which the injury involves only the epidermis, while in the second degree burn the injury gets deeper and the dermis is involved, and in this case a blister will form. In third degree burn, the whole thickness of the skin gets injured, and the level of injury gets down to the fatty layer, and this is called a third degree burn. Sometimes the third degree burn becomes more severe by formation of chars or tafahum, and in this case it is called a fourth degree burn. These figures here shows you what's the difference between these three degrees of the burns. So burn depth means the skin of depth of the injury at the burn region. The burn may be either partial thickness. Partial thickness includes that's to say the injury has involved the epidermis plus minus some of the dermis. So it is partial thickness burn, partial injury to the thickness of the skin, and it includes two main degrees: the first degree and the second degree. The first degree burn, example for it is simple sunburn. It is characterized by involvement of the epidermis only, and there will be inflammation but there is intact epidermis. the inflammation is characterized by vasodilation. It is usually self-limited by resolution of this inflammatory process, and the healing will take 5 to 7 days. Clinically, it looks red and painful. You can see here that the first degree burn is characterized by intact skin but red and painful and dry. If the injury gets more, maybe divided into two subcategories: superficial second degree burn and deep second degree burn. In the superficial second degree burn, the epidermis and only the superficial dermis is involved, and there will be blister formation in the burn area with fluid oozing from it. When it gets punctured, it is very painful, more painful than the first degree, because of the exposure of these nerve endings here. In second degree burn, there is involvement of the deeper dermis. It may look like the third degree burn sometimes, but the difference here is that it is painful, while the third degree burn is painless. Healing in second degree burn, whether superficial or deep, is usually by repithelialization process from the basal cells layer that are present in the remnants of the hair follicles and the sweaty glands in the dermis, and it usually heals in less than 28 days. Any burn that does not heal by 28 days, it means it will not heal by repithelialization, and it requires skin grafting. You can see here that in these two figures that there is much more severe injury involving the dermis, and this will cause ooze of fluid in between the epidermis and dermis, forming a blister, and when the blister ruptures, exposure of the dermis occurs, and the pathognomonic sign of second degree burn is this ooze of plasma. Whenever you see a wet burn, it is usually a second degree burn. Full thickness burns, on the other hand, involves the total skin layers, and it is usually divided into either a third degree or a fourth degree. It is usually painless with a dry scar, and the injury gets down to the fatty layer, maybe into the muscle or the bone, and the fourth degree, as I said, there is charring. It usually heals by secondary intention, that's to say granulation tissue formation, or and the scar formation, or it requires skin grafting. You can see here in these figures that this is a third degree burn. The scar, you can see it is white, just like a liquid wax on the skin, and here also a third degree burn with charring. Once the areas in which there is charring are 4th degree burns. You can see also in the figure down to the lower right side, there is thrombosis of the superficial veins and the vessels of the skin, and this is pathognomonic for 3rd degree burn. Whenever you see these vessels under the scar, it means that the burn is 3rd degree. So the characteristic clinical feature of 3rd degree burns and 4th degree burns are painless. This tables here summarizes the clinical pictures of all the 3 degrees of burn, and you should remember only the most important features is that the 1st degree burn, the skin is intact and it is dry and painful. The 2nd degree burn, the skin is blistered or is wet and it is more painful than the 1st degree. The 3rd degree burn, the skin is characterized by formation of scar, which is just like a liquid wax, and it is painless, while the 4th degree burn is usually characterized by charring or tafahum, and it is also painless. The 1st degree and 2nd degree usually can heal by spontaneously by just change of dressing, while the 3rd and 4th degree requires surgery by skin grafting. If it is left without surgery, it will heal by scar formation and ends with contracture and disfigurement. Pathophysiologically, effects of burn on the body are divided into local effects and systemic effects. The local effects include direct cell damage by the injuring agent. This will release inflammatory mediators that causes thrombosis of the microcirculation in the burn area and marked inflammatory response. There will be increased capillary permeability, causing generalized body edema and fluid ooze from the burn area also. There will be body and electrolyte disturbance as a result of that, with protein exudation, such as oozing of the albumin and the plasma from the burn area. Finally, there will be wound infection, since the skin hair has been damaged and will become vulnerable to bacterial invasion. Systemic effects of burn include shock, and this may be either neurogenic shock by the pain or oligemic shock due to the third space sequestration or generalized body edema. Therefore, severe burns require IV fluid being given to the patient. Those patients also has depressed immunity because of the wound infection, and this causing wound infection and septicemia. The depressed immunity is due to release of unknown agents in the burn area. There will be also toxemia due to electrolyte disturbance, infection, and the toxic products of the burn. Some patients develops respiratory failure due to organ failure or due adult respiratory distress syndrome due to the inhalation of the smokes and chemicals. Some patients develop GIT problems, ileus, or ulceration of the stomach due to the stress. There will be multiple organ failure due to the long-standing hypotension. Some patients develop anemia, hypoproteinemia, electrolyte and acid-base disturbances. Some develop UTI due to catheterization for input-output calculations. Some patients develop venous thrombosis and even pulmonary embolism due to prolonged immobilization in the bed. Eventually, some patients get scarring or contracture and malfunction of the joint, and eventually some develop psychological trauma, especially when the burn is very severe, involving the face. Now, this is very important. What are the indications for hospital admission? Whenever you encounter a patient in the emergency room or in the outpatient, you should decide whether it should be treated as an outpatient case or an inpatient case. So what are the cases in which you should admit to the hospital? This includes burns of partial thickness, that's to say second degree, more than 15% total body surface area in adults, or more than 10% in children. Why do you admit these two cases to the hospital? Because at this level the burn patient cannot compensate the loss of the fluid by oral intake, and he will require IV fluid therapy. Therefore, you should admit him to the hospital for input-output calculations. Also, you should admit all cases in which there will be full thickness burn, that's to say third and fourth degree, of more than 5% total body surface area, because they require special care and requires skin grafting in the future. Both extremes of age patients, that's to say very young and very old patients, age patients should be admitted because they require special medical care. Also, patients with associated serious medical illness such as diabetes, CVA, myocardial infarction, etc., because they are more liable for complications. Also, burns involving the face, the hand, the feet, and perineum, because these areas are usually develop severe burns that eventually lead to disfigurement or malfunction and requires specialist care in the hospital. Also, patients with inhalation injury, that's to say those patients who has inhaled the smoke or hot air in the burn area, and this usually happens when the burn patient is in a closed space such as a burning car. The lungs of those patients, they develop pneumonitis and then pneumonia and requires special care, and therefore they should be admitted to the hospital for this care. Electrical injuries should be admitted to the hospital because the electricity passes through the body and causing dysfunction of the heart and the CNS, and even they causes microthrombosis of the microvasculature and eventually ends in gangrene. Therefore, those patients should be admitted to the hospital. Also, cases in which they are due to chemical burns. Some chemical burns are toxic, such as the phenol, and requires admission to the hospital. Then we have patients with social factors, such as those who have not care providers at home, should be admitted to the hospital. Also, burns with associated injuries, such as those burns in which the victim has been exposed to road traffic accident or blast injury, and therefore have associated injuries such as ruptured liver, spleen, etc., and should be admitted to the hospital. Now, how you manage the patient with burn? There are three main sites for the management. First, at the accident site, that's to say before you transfer the patient to the emergency room. What you should do to this patient is usually you should remove him to a safe place away from the injury site. You should also irrigate the burned area with cold water as much as possible to dilute the heat or to dilute the chemical agents if present, to give him a pain relief by IV morphine, slowly diluted, titrated to the patient pain. Then transfer the patient by ambulance, avoiding any wound contamination by placing a sterile blanket on him. When the patient should start putting the two good IV lines and take blood samples and send it for blood grouping, PCV, because this PCV will consider the baseline, and you will check the rehydration status of the patient. You should check the serum electrolytes, the albumin, acid-base urea, and creatinine. Then you should insert a Foley's catheter for input-output calculation. Take wound swab from the burn area and send it for culture sensitivity, and insert an NG tube if the burn is more than 28% total body surface area, because the patient with this degree of burn will have paralytic ileus and may vomit. Therefore, you should tell him not to take anything by mouth, and if he started vomiting, then you should insert an NG tube to get rid of that. Then, when the patient, after stabilizing the patient in the emergency room, you have either to transfer it to the burn ward or by ambulance to a hospital with a burn ward. And when you transfer the patient, a burn patient, to a hospital with a burn ward by ambulance, you should always send a rotator or a doctor with him so that he delivers the patient to the burn unit at that hospital and return back to his duty. In the burn unit, the patient will be managed by estimation the burn surface area, and by estimation his body weight. The burn surface area is estimated by three methods: either the rule of 9, Lundebruder chart, or the patient palm surface area. You should notice that the patient palm, not the doctor palm, and this patient palm represent 1% total body surface area. يعني انت تشوف المنطقة المحروقة كم ايد من ايد المريض تغطيها، فعدد الايدينات تضربه في 1% تطلع مساحة الحرق. فإذا مثلا 1% يعني معناته كف واحد يغطيها، 2% محروق يعني معناته كفين يغطيها، وهكذا. Rule of 9 method usually used by the body parts are divided into مضاعفات التسعة. فإن راح الرأس كله 9%، يعني 4.5 بالأمام الوجه و4.5 بالخلف. البودي الانتريور يعني الصدر والبطن 18%، الرجل 9% من قدام، 9% من وراء، فهم 18%. آخر شيء يبقى 1% هي للبرينيوم، والأبر لمب 4.5% من قدام، 4.5% من وراء، مجموعها 9%. فمجموع الإيديانات يعني في المجموع البودي بارتس بالحالة يصير 100%، كلها مضاعفات التسعة، يعني 9% للرأس، 9% لكل ايد، 18% للجسم من قدام، 18% للجسم من وراء، 9% لكل lower limb، 1% يبقى للبرينيوم. هاي الطريقة roughly estimates the surface area of the burn. The accurate way is by the Lund-Bruder chart. هاي تلقوها بردات الحروق. هنا يدخل عمر المريض بالموضوع، لأن أجزاء الجسم ما متساوية بين الأدلت والطفل، فنلاحظ الطفل نص جسمه راس، بينما بالأدلت الراس ما يعادل 9% من جسمه. نلاحظ هنا باللندن-برودر شارت تقريبا الأبر لمب همين 9%، اللور لمب هنا ينطي للثاي بي وللليج سي. وبعدين اكو جدول لي جوا تلاحظون انه كل عمر شي يمثل الاي هو الوجه من قدام، وال يعني الوجه والسكالب من وراء، فكل وحده شي يمثل حسب الايج، اقل من 5 سنين، من 5 سنين الى 10، من 10 الى 15 وفما فوق، وكل وحده بيها نسبه محدده للاي والبي والسي. فانت بالرد تشخط الاماكن المحروقه وتقعد تجمع الارقام وتقول هل قد بالمية محروق من هذا الجسم. After that you should give the patient analgesia, and as I have said, analgesia in any case of severe pain, it should be always diluted and IV, either morphine or pethidine, and it is given slowly until the pain is relieved. Then you should start fluid resuscitation, and fluid resuscitation we use crystalloid solutions in the first 36 hours. There are many formulas. The most common one is the Parkland formula. The Parkland formula estimates the burn patient fluid requirement by multiplying 4 ml of fluid for each kg of body weight for each burn surface area. Therefore, in the first 20, this is the fluid requirement in the first 24 hours, and as I have said, usually crystalloid, either Ringer lactate, Ringer or normal saline, and the half of this quantity is usually given in the first 8 hours post burn injury. Then the other half is given over the final 16 hours. You should note that this is calculation is based on the time of the injury, not the time of patient arrival to the emergency room. يعني إذا محروق ساعة 4 العصر وصلك ساعة 8، فحسابك لازم يكون من ساعة 4 العصر وليس من ساعة 8 لحظة وصوله للطوارئ. فلازم أول 8 ساعات من ساعة 4 عصر، يعني من ساعة 8 إلى ساعة 12 بالليل راح تنطي نص هاي الكمية، ومن ساعة 12 بالليل إلى ساعة 4 ثاني يوم راح تنطي النص الثاني من هاي الكمية. ثاني 24 ساعة تحول الكريستالويد إلى dextrose water 5% to maintain the urine output at 30 to 80 ml per hour. هذا هو حسابك. الأهم شيء إنه الحافظ على urine output من 30 إلى 50 مل بالساعة بالأدلت، أو 1 مل per kg per hour in children. فإذا المريض مثلا دي يطلع يورين اوتبوت أقل من هاي الكمية لازم تزيد الاي في فلويد، إذا دي يطلع أكثر تقلل الاي في فلويد. ثالث 24 ساعة تعطي المريض ذاك مينتنس اي في فلويد، ويبدي ياخذ اورال انتيك اور انترال فيدينج. إذا تستخدم بلازما افيلبل فلازم كل باينت بلازما يعادل تقريبا يعني half the estimated fluid requirement. يعني شلون؟ إذا عندك باينت بلازما تشيل مقابله باينتين من الكريستالويد، فكل باينت بلازما يعادل باينتين كريستالويد، يعني تلغي من حسابك باينتين من الكريستالويد مقابل كل باينت بلازما تقدر توفر للمريض، ولا يفضل أن تعطي بلازما خلال أول 18 ساعة من الحرق. The fluid requirement is increased if there is associated vomiting, gastric aspiration or diarrhea. شلون تتأكد المريض ماخذ فلويد صورة كافية؟ اكو either clinical guidelines or laboratory guides. The clinical guides تلاحظ consciousness orientation مال patient، is it oriented, is it drowsy, etc. تلاحظ البلس ريت لازم أقل من 100 pulse beat per minute. فإذا أكثر معناته he is in shock and acquires more fluid. check blood pressure if he is hypotension or not. طبعا blood pressure بالبرن شوية خداع لأنه ممكن يعطيك false high blood pressure due to the peripheral vasoconstriction. respiratory rate إذا المريض يتنفس بسرعة أكثر من 20 cycle per minute معناته he is in shock and requires more IV fluid. تسمع lung basal crepitations إذا المريض ماخذ IV fluid أكثر من اللازم. الابيتايت حالة المريض اللي not in shock he is in good appetite while the patient in shock usually have lost appetite. البowel motion تسمعها إذا he is in ileus or not. Abdominal distension means that he is ileus and in shock. Urine output should always, and this is the most important clinical feature, you should always maintain a urine output which is نص إلى 1 ml per kg per hour using يعني الشارت ونفس الوقت تحسب اليورين specific gravity وهاي طبعا لها يعني جهاز خاص حسابها. فإذا المريض ماخذ فلويد أكثر من اللازم راح يطلع diluted urine. إذا فلويد أقل من اللازم راح يطلع concentrated urine. تلاحظ skin turgor and temperature يعني recoil مال السكن إذا المريض dehydrated or not. laboratory guides include PCV. المريض إذا dehydrated ال PCV يصعد. acid base status المريض من يكون dehydrated يصير acidic state. اليوريا and electrolytes تصعد اثنيناتهن إذا مريض dehydrated. وآخر شيء عندنا central venous pressure and this one Gans catheter. هذين يستخدمون قيسا البريشر بالرايت اتريوم بالهارت خلال long catheters. المريض بس يحتاج فلويد يحتاج نوبات بلاد بلازما البومين ريبليسمنت. تعطي انتي بايوتيك اذا المريض وايد بيرن بنسلين او جرام بوزيتيف cover in first 5 days. Then you should cover gram positive and gram negative. تعطي tetanus prophylaxis إذا المريض ما tetanus not well يعني completed tetanus immunization. You should prevent gastric ulceration by giving the patient oral sacral feed or NG tube insertion. High protein and high calorie dietary support, parenteral or enteral, nutritional support, psychological support, and rehabilitation and psychotherapy. What you should do to the local burn wound itself. The patient should undergo daily bathing with soap and water, preferably using a shower. السوب هنا لازم يكون بدون chemicals نفضل صابون الرقي. الووتر لازم يكون ستيرايل اما فوري ومبردي او يستخدمون مي الشرب مال البطاله اللي معقم بالاوزون. زين ورا ما تغسل الحرق بالمي والصابون تنشفه زين sterile goes. Then you should apply local antibacterial agents. You should apply local antibacterial agents. These are antibiotics, not antiseptics. Avoid any antiseptic on open burn wound. The antibacterial agents or antibiotics used include either sulfamylone or mefenide acetate, and this is usually used for infected burns, especially those infected by Pseudomonas. It is why it is reserved for infected burns, because it is expensive and painful, and those patients and it has very good penetration to the dead tissue. Therefore, it is very useful for infected burns. Otherwise, if the burn was not infected, you can use silvadazine or flamazine. It is usually used for prophylaxis unless the patient does not have sulfamylone and he has infected burn, then you can use it for infected burns also. Other antibacterial agents include the povidone iodine cream, silver nitrate, vinegar, aloe vera, garamycin, etc. But all of them are weaker than the silver sulfadiazine and the mefenide. Then after that after you apply the antibacterial agent, you should do burn wound dressing. Either there are two methods, either closed method or the open method. The closed method, that's to say the application of dressing by gauze, you should it is usually applied twice daily لأنه الدهن يفقد مفعوله ورا 12 ساعة. It is useful for the extremities and hands, but however it is costly and increases the risk of infection and contaminated burns لأنه الجرح من تسد تغطيه وتضمده فإذا بي contamination راح يتحول إلى infection. الأذر الميثود هي الأوبن ميثود. It is usually useful for large surface areas يعني مع الجسم مثلا الفيس neck والtrunk. In this case you keep the burn area exposed to the air in a warm isolated room يعني غرفة معقمة مثل صالة العمليات تكون معقمة. However there is risk of contamination لأنه مفتوحة للهواء فلازم المنطقة تكون معقمة, otherwise it will be get contaminated. There is also loss of heat and fluid in this method. Finally, you should always whenever you change the burn wound dressing, you should check for any wound infection signs such as cellulitis. You should also treat special burned areas such as the eye by application of an antibiotic ointment and the closure of the eye for 24 hours to protect it from dryness. Ears by application by avoiding pressure on it and application of antibiotic ointment and drainage any pus collection to avoid suppurative chondritis. Limbs, use of handbags and physiotherapy if the burn involves the hands. handbags يعني شنو كيس نايلون معقم تخلي بيه فلامازين وتدخلها الايد كلها بيه بدون جوز وتسدها وتغير الكيس مرتين باليوم يعني كل مرة تفتح الكيس تذبه تغسل ايد بمي وصابونها مرقي وتجيب كيس جديد معقم تخلي بيه فلامازين وتدخلها الايد بداخله وهكذا. Prognosis of burn patient depends on the age. طبعا كل ما يكون البيشنت young age or old age the prognosis will be worse. Burn surface areas, any burn area that is larger than 30% usually carries a bad prognosis. Burn depth, whenever the depth of the burn is more deep, it will get worse prognosis. If there is an associated injury such as inhalation injury, pre-existing medical illnesses, especially diabetes and heart diseases, are very detrimental to those patients. Early and effective management, the earlier the management, the better the prognosis. Of course, of these 5 ages that is very detrimental or to the patient is the presence of inhalation injury. Whenever the patient has an inhalation injury, he has a very bad prognostic feature. Early and late complications. The early complications include hypovolemia if the patient has no adequate IV fluid resuscitation, or he may be getting overloaded with the fluid, and this is usually iatrogenic. Patient may develop renal dysfunction such as renal failure due to bad resuscitation. Hemoglobinuria, in cases of electrical burn, those patients develop myoglobinolysis, the release of myoglobin in the blood from the injured muscles. Therefore, those patients, that's to say those with electrical injury, requires infusion of mannitol together with the IV fluid. You can see here that this is the only place in which diuretics are given in burn, in electrical burn. You should never give a patient with burn diuretics unless he has electrical injury. Otherwise, you need to increase the IV fluid rather than give him diuretics. Patient may also develop stress ulcer, which is called stress GIT ulcers, Cushing ulcer. Some patients develop adult respiratory distress syndrome, pulmonary dysfunction, asphyxias, inhalation injury, pneumonia, etc. Some patients develop brain encephalopathy due to the release of toxins. there may be local and systemic sepsis, either septic shock or burn wound infection, thrombophlebitis, etc. The late complications of burn include scarring, whether hypertrophic or keloid, and this may eventually lead to contracture of the limb, neck, etc., hypo and hyperpigmentation, and usually this happens in second-degree burn after recovery of the burn area by repitalization, and this is simple sequelae. Disfigurement if there is severe scarring of the face, facial burns, functional disability of the joint, or psychological trauma such as post-traumatic stress disorders, and usually those patients require psychotherapy. Thank you very much.